Welcome everybody on this very hot afternoon. Thank you so much for joining us today for what will hopefully be an interesting debate. As David said, really keen to get your questions involved in this discussion. So you'll see at the bottom of the screen an opportunity to put in your questions, and I will pick those up through today's session. I can see people saying hi, so hi, great to have you here with us. Today's session is all about digital healthcare ecosystems and technologies for patient or people's empowerment. And the reason this is so important at the moment is with the backdrop of COVID-19 and the crisis and the pandemic that we're currently living in. So since the pandemic, we have all recognised that digital at large has never been more important, and digital health at large has also been never more important. For those of you who don't know me, I am the founding chief exec at Orcha, who is an organisation that works across the world supporting systems to know which solutions are safe and then distributing them to patients and populations via digital health libraries, which healthcare professionals can use to recommend or prescribe solutions to their patient's phone. And we've seen an increase in the number of recommendations to the tune of 6,500%. And that's because our populations are looking to self-manage, particularly those patients who live in vulnerable groups. We've also seen a massive rise in digital technologies around teleconsultations, where just in the UK alone, we've seen a shift of 30% of all primary care appointments now being teleconsultations, now being around about 90%. And obviously some policy changes from our health Minister Matt Hancock, who is obviously mandating that we use technology first. So this topic around how we can empower patients to use technologies is really important. And I'm absolutely delighted to be moderating today's session, and we have some fantastic panellists. The way I'm going to structure today's session is to ask each panellist to just briefly introduce themselves and their work, and then I've got a range of questions for us to discuss, and I'll also pick up on questions that you have as delegates and bring those into the discussions. This session will close at 3 o'clock. If there are any outstanding questions, I will invite the panellists to respond in writing. I'd first of all like to invite Chris Barker to introduce himself and his work. So Chris describes himself as Chief Mischievist, which I might steal actually, and the CEO at Spirit Health Group. So over to you, Chris, for a little introduction.
Yeah, thanks, Liz. I've been asked to keep it very brief. So my formal job title is Chief Exec. My preferred job title is Chief Mischievist, largely because my job is to ask all the really difficult questions. In terms of Spirit, we have 3 different parts to what we do. One, we're a service provider, both in the UK and internationally. So we provide primary care and intermediate care services. Secondly, we have a range of products, so prescription products, that we work with health systems to save money and enter into the market. And then the purpose of today's call, we have a digital health product, which enables people to do remote monitoring of individuals with long-term conditions, and also people who are wanting to be proactive in their healthcare. I'm not going to say too much more, Liz.
Thank you, Chris. We will definitely touch on some of those points as we move through the discussion. So thank you, Chris. So I'd now like to invite Michael Morgan-Curran, who's the Commercial and Clinical Development Officer at MyCognition, to just very briefly introduce himself.
Yeah, thanks very much, Liz. And it's very nice to meet everybody on the other end of the call. Yes, so I look after commercial and clinical development at a company called MyCognition, which is basically a cognitive health company specializing in mental health. But I'm also an owner and director at another company which miniaturizes digital technologies, and in particular ECG devices. So I have an expertise in chronic disease management and delivery of services remotely. And then I sit on a number of boards with other digital startup technology companies. Thanks, Liz.
Thank you so much, Michael. That's great. I'd now like to invite Henry Etukumoh, who's the Chief Exec and Founder of Miksatko, to briefly introduce yourself and your work.
Yeah, hi everyone. Great to be here too. My name is Henry Etukumoh. I am the founder and CEO of Miksatko. We are a health tech company that provides digital infrastructure and timely access to medical expertise, particularly the UK, for care providers across Africa. And our aim is to improve clinical efficiency and patient outcomes, in a continent that is suffering greatly from a huge digital divide. Thank you.
Thank you, Henry. And last but by no means least, we have Jan Miksatko, who's the Executive Director at Ententee, apologies. And I'd like to let you come to the floor now and introduce yourself.
Hi Liz, hi everybody, nice to meet you. Yeah, so my background and what I do, I have been basically running since 15 years a small software development shop, which is highly focused on healthcare solutions and applied AI. I'm by background computer scientist, and since 2005, since my studies in the US, we've been working on various interoperability standards, reference implementations of those standards, then later on big health information exchange solution, which is currently used by a major US vendor and sold globally. And over the time, we have implemented many software projects in the areas of EMR systems, smart medical devices, system integrations, or also on the payer sides for the management of insurance policies. And this work we have been doing mainly like for startups and large corporates in US, UK, Germany, Switzerland. And I think what we have and what we gained is very deep insight into the IT part of healthcare and also into different healthcare ecosystems as we work globally. And this is what we offer.
Fantastic, and thank you all so much for your introduction. Everybody, you should be able to hear that we've got a fabulous panel for you today. What's really interesting is they each come with different experiences in different countries and jurisdictions, which I'm going to come on to later. But the first question that I wanted to pose to the panelists is, we're talking today about technologies for patient or person empowerment. What do you mean when we talk about technologies in health and care? And what do you call it? And does it really matter what we call it? So I'm going to ask, Chris is smiling, and I just asked a really challenging question. So I'm going to steal your role title, and I'm going to invite you to take the floor first, Chris.
Yeah, not an easy question to start with, but thanks, Liz. So, yeah, for me, weirdly, the title of this this webinar is about digital healthcare ecosystems. And actually, my preference is that it's just called healthcare ecosystems, because actually what's successful about technology and making it work is actually just making it normal and making it a par for the course. So yeah, there's brilliant examples of lots of digital tech out there, both on the panel and broader than that, that can help patients. But actually the biggest challenge that we perceive, and that I think is shared by many, is about how it's used in practice and how it brings to life the reality of the potential that it offers. So for me, on a really personal level as well as a company level, this is about how we don't try to make fancy words for what we produce and what we make real. We don't call it digital health. We just talk about healthcare and how we make it real.
I think that that's absolutely critical, and you're absolutely right. How do we normalise digital to just be part of healthcare? I suppose that one of the success criteria will be when we stop calling it digital health, and when it, as you quite rightly say, it just becomes healthcare.
As I point out, it says digital health unlocked behind you.
Absolutely. So it's a really good point. So why do we still talk about digital health? And I was just going to come on to that exact and ask the panelists, but I will give my perspective. So for me, we're on a journey. And where you've just described is where we absolutely want to get to this world. However, at the moment, we're not quite there. So there is a digital health journey to be on. And for me, it's a normal distribution curve. Some people are using digital health as part of their everyday work life. And that's where we want to get everybody to. But we need to shift that normal distribution curve up, and that's obviously the work that we're trying to support alongside great people like you, Chris. So anybody else from the floor? Michael, I was going to ask you what your thoughts were on this idea of what do we mean by technology and digital health?
Well, I think you're absolutely right, Liz, and going back to what Chris was saying, we've been on a journey. I remember years ago when I started supporting the GSMA, which is the Trade Association for the Mobile Phone Industry. So it's a bit like M-Pharma or the ABPI, but on steroids, and it represents all of the big operators around the world. And I was commissioned to develop their M-Health, their mobile health program, which was basically building on what they were doing around telehealth and telemedicine in the US. And one of the phrases that we wanted to adopt was actually connected health. And I think that's what we're going to be looking at in the future is connected health. Digital is just the vehicle to it. Once we've normalized digital, then we can talk about having proper connected healthcare ecosystems, of which digital plays an important role, and not only the devices that people use in their own homes, whether it's companion devices, diagnostic devices, or app-enabled devices. And let's face it, apps are just another conduit for transferring information or displaying information to the user. But more valuable than that, then we can have that data then used in real-time analytics to support and connect the rest of the ecosystem together, the hospital-based system, other primary care-based systems. We can share that data then with other users and then build up better value propositions around other digitally enhanced services. But it's all about connectedness for me is the real feature. And I know, and going back to the theme, which is all about the ecosystem, it's important that we consider the other players that are going to be involved in this and who we need to partner, who we need to collaborate with, I think.
I think that's a critical theme, isn't it, Michael? The collaboration piece.
Yeah. So and as representing several different companies and owning several different companies that I do, I do often have to just wear the very siloed hat about my own self-interests and what is it am I going to do to make my company successful or the companies I work with successful. But I have to consider that I'm not working alone. I can't work in silo. I have to be cognizant of everything else that's in this business model that I'm working with at the moment.
Absolutely, and I think that what's been really exciting and interesting about the current landscape is we are all focused on the same mission. We're all focused on the current crisis. We're all trying to support health during the crisis, and we're becoming very person-centric and making sure that we enable the person to be able to manage their own health in the best way possible. And without that collaboration, that wouldn't be possible. So I just wanted to bring in Jan and really just ask, obviously you've got such an interesting career and you've worked in lots of different countries. And I was just going to ask you, where do you see where people or patients are at the moment in their thought processes in using technology for health and healthcare?
And now, please tell me a little bit more about your question. Is it where I see like the digitalization most advanced? Is this your point?
So no. So I suppose the discussion so far has been from a technology perspective. What do we mean by health, digital health, and the technologies? And what we've just been talking about is that there's a journey to getting digital health to just be called health. But then obviously today's session is all about how do we empower people to use digital health. And so we've talked about the journey of systems thinking about digital health, but how about how people are thinking about it? So my experience and our experience at Orcha is that most people don't actually know that there are digital health solutions available that could help them. But what's your perspective on where people's thinking is around using digital to support their health?
Right, and you are probably this is a difficult question, tough one, but it depends on the viewpoint. So if I look at it from the patient viewpoint, I would say the patient do not perceive as any difference between like digital and health system. I mean, they use smartwatch, they use some cell phone applications. They can get maybe not prescribed, but they can buy online an application for meditation, for, I don't know, Parkinson's disease recognition, and there are many solutions like that. So for patients, I think this is kind of fusing into the patient empowerment, and the digitalization is becoming part of the for normal people of their life, like the cell phones became part of their life. On the other hand, and the technology is for there, and I think the technology is well matured. On the other hand, where I see gaps is in the healthcare world, and I mean now in hospitals by physicians in the healthcare IT, where this is still not easily integrated. So the physicians, they do not accept, if I come to my GP, they won't accept data from whatever app which I bought online. There is a valid question: are the data valid? Is the data processing valid? If the app uses some kind of machine learning, so how can the GP be sure that there is no bias? This is very important. Another point is how the vendor of this application incorporates the data into the EMR system of the hospital or of the GP. How that this whole work with the patient remotely is incorporated in the workflow of the healthcare provider. And I think those are the challenges that needs to be addressed and solved.
And I think, Jan, what you picked up there is a really interesting discussion point, which is patients and people are already using these solutions. They're going out buying wearables, they're going out downloading solutions. And one of the frustrations for people is that they can't then share the data. Before I do a bit of a deep dive into that sharing the data, I just want to bring Henry into the discussion. And I just really was interested in your perspective of how people may or may not be feeling empowered in other parts of the world.
My perspective would come from my experience in Africa and what people's perception was of digital healthcare pre-COVID-19 and now that we're going through the pandemic. So in 2018, when I went to Nigeria and I started talking to people about telemedicine, telehealthcare, because that was our original service offering. A lot of people did not understand or even heard of the word telehealth or telemedicine. And I had to explain the concept to them. And I had this initial pushback from people because they're so used to the physical interaction that they've always had with their doctors. But post COVID-19, that perception is changing. People are embracing and adopting remote healthcare service because it's now the most practical alternative or options for them to engage with care providers, given that there is this stigmatization of COVID-19 for people who do make physical visits to the hospital. So in general, people are embracing and warming up to the idea of digital healthcare, but I would still take the stance of my co-panelists that have spoken before me. I think normalizing the term and calling it either connected health or for ourselves. I think in Africa it's all about accessibility, having timely access to healthcare, whether that is remotely or physically, making that available and accessible to the patient on demand. I think is the key to quick adoption.
Yeah, I mean that's so helpful, and one of the things obviously that you were touching on is this access point, and this was something that Jan was touching on, particularly with relation to accessing data and being able to share data, and as an end user, being able to share your health data. So me sharing with you that I live with type 1 diabetes, I would love to be able to just share that data with my primary care physician and my diabetologist, so I don't have to go into a healthcare appointment, not least because pre-COVID I was very rarely at home. So that would be a real really empower me to use my data more regularly. And one of the things that we were discussing before this session was all about, well, what does that mean for the innovator? And is it clear what the rules are for sharing data, particularly when, as an innovator, you're not just interested in working in one jurisdiction, you want to work potentially globally. So I just wanted to bring Michael in at this point, because Michael had some really interesting perspectives on this and some of the confusion, which means that there's a barrier to us being able to do that. So Michael, can I invite you to talk us through your thinking in this area?
Yeah, thank you, Liz. So, being responsible for several companies, one of the challenges that we have in this, the companies that I work with are very much UK based. So, two of them are US companies that want to operate and do business here. And it's the same challenge, whether they're based here or whether they're, is when delivering our services and commercializing our services, we need to be able to manage our data, move our data around in the markets that we're working in. And particularly now that in the UK we have the lens of Brexit, and that's going to be looming quite shortly, we're still not 100% sure what kind of data sharing arrangements we will need to have in place in order to protect, the integrity of our patients. They're consenting for their data to be used in a particular way, and for the data to be hosted and shared or aggregated or anonymized in a particular way for research purposes, or to help us with our algorithms and our AI capability, and of course to deliver, and monitor the outcomes that they're interested in. But conversely, where do we store all of that? So it's without the right insight and the guidance, we're still struggling a little bit to figure out what our investment plan needs to look like around that, and who can we possibly partner with, and what commercial arrangements should we be entering into at this stage? Which of them are going to be at low risk, which of them are going to be at high risk, and we work with a number of research organisations, institutions, not just in the UK but also in the US and here too. And if we're embarking on long clinical evaluation programs and studies where our technology is being used assistively or exclusively within those programs, what do we do in those scenarios? So it's all a little bit unclear. But don't get me wrong, the right kind of network infrastructure and security and all of that is really, really important. We just need some clear guidance as to what we need to do.
Yeah, this is exactly the area that I'm particularly passionate about, which is around building trust. And the reason trust is so important is because unfortunately a lot of innovations don't meet those requirements, and part of the reason is because they don't know which requirements they have to adhere to. I just wanted to bring Chris in at this point, because this whole data sharing piece is quite interesting, and I know that you do a lot of work around building collaborative relationships between patients and healthcare professionals. And I was really interested in your perspective on this data sharing piece from people or patients and healthcare professionals, and what the viewpoint is, and what's your experience of enabling that, and what do people feel about receiving or pushing that data?
Both my favourite person in our organisation and the one that frustrates me most, Liz, is my head of governance, and her specialism in information governance and data sharing. And she's brilliant because she can navigate some of the hurdles that are required, but she's a nightmare because she also creates lots of them as well. So I think from a person or a patient or a citizen perspective, actually for the most part, they echo what you said, Liz, which is actually, why can't I share what's useful and important and vital for the journey that I'm going on as an individual with the most appropriate people? From an organisational perspective, we've got the rules and the boundaries and the laws that mean that we have to be careful around what we do that. And I think I echo some of Michael's comments around actually some guidance on what's happening, from a UK and a European perspective with that dreaded B word, Brexit. But because actually what we should be doing is enabling people to be connected, enabling people to have access to information and to share that where they choose to. And if the systems and processes could do that, that would really help the patients and the people that choose to do that.
And just to add to that, Chris, how do you find, for people who don't know, I am a clinician by background, who worked in the NHS for 20 years. What's your sense from the healthcare professionals' perspective and how they feel about receiving that data?
If I was to, we're coming on to challenges, I think, shortly, but if I was to pick the biggest challenge that I see particularly in the UK, but also internationally, getting healthcare professionals who've been accustomed to helping to improve people's health in one way and getting them to engage in a new and slightly different way is probably our single biggest challenge. Yeah. And that's not because there's a lack of willingness, it's because of people being scared, concerned, understanding one way and being asked to do something differently. So from a clinician perspective, they're often, on one hand, quite keen to go ahead and try something and do it. On the other hand, cautious, nervous about what the rules and regulations say, nervous about the integrity of data they're receiving and how they're receiving it. And it's a challenge for those individuals, so as in those healthcare professionals. So actually, there's a big piece of work to go and do about how we take I forget what there are in terms of clinicians, but there's certainly 1 million employees across the NHS, and there's a massive number of people that we need to engage to move them from a healthcare system where driving around seeing patients face to face is normal in a community setting to a world where actually, would you like to go to the home hospital today, or would you like to go into hospital, because the choice is yours as an individual. And both of those are open, both of those are possible, both of those are technologically possible today, but from a position of a system and a process and patients and clinicians, we're still in.
Yeah, no, I mean, and I definitely echo that. I think, as a healthcare professional, I trained well over 20 years ago in my clinical profession, which was speech and language therapy. But what I would say is that unfortunately the curriculum of training healthcare professionals for the future still doesn't include digital health and that toolkit. And that's a real challenge, because if we're not aware of it, we're not empowered. And I think that that's really what we're talking about. It's not just about empowering patients and people, we also need to empower the professionals. Chris, you look like you want to come in there.
Yes, I was going to give an insight so we in the UK run lots of primary care services, so we have GP surgeries that we work with as well and that we manage. And our GPs pre-COVID, and I don't mind me sharing this, were hugely sceptical of how effective teleconsultation, so simply getting on a video consultation with a patient could be. And they weren't scared because they didn't understand how to use the likes of Microsoft Teams or Skype, while some of them didn't. They were really nervous about what that would mean in terms of the clinical effectiveness of those consultations. Along came COVID, and suddenly they are doing nearly everything virtually, either by telephone or on video consultations, because the relative risk versus the reward of the two things shifted.
Absolutely, and I think you've absolutely hit the nail on the head there. That's exactly the wording that I always use, which is risk versus reward. And I think a big part of that is empowering people. And when I say people, I'm including healthcare professionals in that line, to know what the risks are and know what the rewards are. I mean, just on a practical level, as a healthcare professional, one of the scary things is if all these people and patients are going to be sending me their data, how often do I have to look at it? Do I have to manage the risk of seeing that data? And I think that is a genuine barrier. It's a scary position. And Jan, I know that you work particularly in this area of interoperabilities and healthcare information exchanges, and that's been a big part of your work. How far off are we really in getting the data flow from these hundreds of thousands of digital solutions into clinical environments and into the healthcare professionals' hands?
It depends on the country, but for instance, in the UK, you are very far actually. And, the HIEs, the installations that we have in the UK, they connect many different healthcare providers in the ecosystem. So not only the hospitals and the GPs, but also the social care and mental care, and it is and so on. And it is very wide, and it is the HIs are still growing and adding new data sources and additional data sources. So, for instance, UK is great, but if you look on Czech Republic or at Germany, and there is almost nothing. Yeah, so it really depends on the country. And you also mentioned a while ago something about the regulations. Here, the regulations they differ a lot among countries. The legal systems are different. Also, how, for instance, how the organizations that run an HIE, who pays for the HIE, it's not for it has some cost to run an HIE and store the data, right? So this is also different among various countries. So there are those barriers. When you mentioned the risk from a physician point of view, I don't see there any risks, and I think that this barrier shouldn't be there, because the technology is already mature enough to be secure and to provide the right data to the right physician. This is possible, yeah. And also the way how we integrate with different products, this has also improved a lot. For instance, fire standards or Smart on Fire initiative, this makes a big shift in how we can integrate different data sources.
Thank you. That's really interesting. And I'd like to bring in somebody else's opinion. I'm going to bring in Henry right now to just get your opinion as to how far off are we in really getting these data flows happening so that people can really see this connected health, either at the healthcare professional system level and at the patient level. And then just to give the panellists a little bit of room to think about this, I'm then going to come on to procurement and who pays, because Jan just really touched on that. So I'm going to come on to that, get your thinking caps on. So yeah, Henry, if you can give us your opinion, I'd really value it.
Right, thanks, Liz. So I would explore that from the patient and the care provider's angle. So from the patient side of, like I said, this is new territories for healthcare in Africa. And from the patient's perspective, I think they're a lot more worried about data portability. So where patients or consumers' data are stored in walled or closed platforms, and subjecting them to a vendor lock-in. Patients want to be free and have the ability to share the data with whoever they want and not locked into a particular platform or vendor. So I think that is one major challenge from the patient's perspective. And from the care provider's perspective, I think it's around the word, I think Mike alluded to that, around the data integrity. So the data integrity and data breaches. So what happens if there's a liability on a data breach? Who picks up the bill? So those are some of the concerns that people are still, tinkering on in the African healthcare space.
Yeah, and I think you're right. What's really interesting about what you just touched on there, Henry, is giving the data to the person or the patient to make the decision about who they share that data with is really powerful and it's very empowering. But you're absolutely right. Who pays for the sharing of that data? Who pays for the innovation? And one of the barriers that I see at the moment is exactly what you've just described, Henry. These environments that are locked down, where actually the more than lockdown, you have to pay to put your data into these environments if you're the innovator. And that's a real challenge, because then you're de-incentivized to share the data. So, I mean, just coming on to that, and I have some thoughts that I'll share in a little while, but just coming on to that, Michael, what are your thoughts about how we can incentivize a system? And I'm not just saying this from an innovator perspective, but it's also about a system perspective. How do we incentivize the whole of the ecosystem, professionals, healthcare systems, and innovators to share?
Yeah, that's a bit of a holy grail question, that, to be perfectly honest. I don't really, I mean, if you'd asked at the beginning of the webinar, can I list any digital ecosystems, that I think are the true definition of what a digital ecosystem is, I can't, to be honest. I can give you lots of facsimiles of and examples of some that are certainly on that journey towards it, but they're not fully connected systems with data at the heart of it, driving all of the decisions, data driving how services are going to be developed, how services are going to be provisioned, and how they're going to be resourced, and the kind of services that are fit for purpose, and all that data, giving us all of the planning data, the health informatics data, the public health data, to make decisions about what the needs are for that ecosystem, that patient ecosystem, and therefore the kind of things that would be economically viable within that economy, and where the investment needs to go. So I don't see any real examples of that, and that in many respects is my answer, because the incentives are relevant then to each of those ecosystem partners. So, for example, I was on a call with the Welsh government the other day, and the new digital officer down there, who wants to start to see in this new abnormal COVID environment, what do we do as hospitals to try and maintain our services, but deliver our services in a different way in this new normal, abnormal environment that we're in post-COVID. And it's about looking at what services in the hospital can we decommission to a degree and then recommission in primary care, or that we could deliver at a distance, from the hospital. So we're still using our staff, we're still rewarding our staff, we may be deploying them in a slightly different way, but we're providing the services now in a safe environment in people's homes and their workplaces, at schools, or wherever they might well be. So they're starting to think of things like that, and they're starting to think about how they would change the specification of people's roles and those kind of services. So for me, that's really quite good that people are starting to think like that. There's a massive sea change that's required in this whole planning exercise. So when we talk about data sharing and data governance and all, that's really, really important, obviously, but we still need to think about, well, regardless of whether we got the data governance in place, what kind of thing are we trying to deliver in the first place, and then build the governance around it. I mean, I've always been a great believer that the regulation should follow, it shouldn't dictate, and where we've seen it in that order, things have innovated very, 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 very quickly, and been able to monetize as well. Because once we've built out a business model in this new environment, then we can start to incentivize the hospitals, the primary care organizations. We all know that shifting care into the community is a good idea, but it may not necessarily be moving care into the GP surgery or the GP practice. It's positioning it in people's homes, it's people's community environments. That's where the cost of care is going to be reduced, and that's where I think the patients then themselves are starting to take more of a decision in the kind of healthcare services that they need. And so the whole economy, I think, will need to shift. But you all you need to do is to start with one particular kind of service model, disease model as a case study, At the moment in this digital ecosystem, I'm seeing a lot of players, a lot of different companies doing this, that, and the other, but nobody really thinks strategically in this COVID environment how they're going to develop something that's going to be compelling, that's going to provide the right kind of data, and then can back up with the right kind of AI behind it to inform better services, if that makes sense.
It does, absolutely. I think what you've touched on there is this, we've got different tiers, and you've got the whole system and how they are incentivized to work collaboratively to enable the flow of money across different parts of the system. And currently, as we know, money is locked into elements of the system, and therefore parts of the system are not incentivized to look at the whole of the picture. And I think that, then we can... Right. Sorry, Michael.
No, you're absolutely right. And because, if we look at the UK as a particular example, most general practitioners are measured on the QOF performance, the quality indicators. But to be perfectly honest, it's, that's only a quality indicator of a particular cohort of the population. It's the ones that meet the criteria for QOF. It's not the whole population. So it's only an indicative measurement, But you get rewarded on outperforming well in that small cohort. It's not necessarily the right kind of incentive to have in place for delivering innovation and different kind of new care models.
Yeah, and I think, one of the things that I heard when you were talking, I'm going to bring Chris in a second, is this idea of have the big vision and the strategic plan, but start small and start in an area. And Chris, I'm just wondering if you've got any examples of where that's been successful. I mean, talking about, working across a system, this has been around for 10 years from when we had the big restructure and transforming community services. And it's still on the table. So yeah, just interested in your perspective.
Yeah, so it sounds scary to say that we started our first digital health pilot about 8 years ago, and we're still now expanding that same pilot and still engaging those same healthcare professionals in that journey. So for me, if I look at what's needed, we have clearly demonstrated that there can be patient improvements. We're not alone in that. There's lots of technologies, lots of systems that have demonstrated they can do patient improvements. What we need to have to incentivize ecosystems and digital health ecosystems is for me, is the evidence, similar to how you'd expect for other products and services. If they're published and peer reviewed, even better. So that standard, that quality, that expectation of what's there. Why? Because actually, particularly in a healthcare system like the UK that's constrained by price, then so cost effectiveness becomes a real issue. And actually, it's incumbent upon all of us to demonstrate that what we're doing is cost effective. So we've been working in Leicester, as an example, in respiratory disease, which is particularly topical because of COVID. And that pilot has now extended so that it's become, as one senior nurse put it the other day, who runs that service, it's now essential and core to what we do. But that's taken us the best part of 8 years of integration work to get there, and probably wouldn't have even got that far had it not been for a horrendous pandemic. I think the final word, and it comes back to one of the comments that I'm seeing on the Q&A as well, is interoperability. I don't like the word because I think it means a different thing to lots of different people. But for me, how we get our system talking to everyone else's system, how we get people to be able to choose what watch they prefer to wear, raising one of the comments from the questions, actually how we get those connected parts of the system talking to them in a way that works for people is really key. So what we have seen, and I think this is really important, is that when all the incentives do align, so when that risk and reward satisfies the healthcare professional need for safety, when a circumstance means that a commissioner is prepared to pay for it, then actually people can pull in the same direction and work together. For me, how we now make sure that we don't go back on where we've progressed in the last few months, to capitalise on the silver lining was a phrase I heard the other day, which I really quite liked. Because there has been some good stuff come out of this horrible situation we find ourselves in. And for me, how we move forward, learning from those things, getting more evidence out of it, demonstrating patient improvements and pulling together some cost effectiveness data will be really useful.
That's so helpful, Chris. And I think that one of the things that you're talking about is this ability to prove impact and be able to measure impact. And I think that that's something that we all need to think a little bit more about when we're either building innovations, deploying innovations, procuring innovations. And it is a bit of a prerequisite to procurement. Now, I was going to share with you my thoughts on this. So for me, I always use drugs as an analogy. So drugs get to the market because they've met regulatory requirements and there's a very proven path and a very clear route into market and payment once you've hit those hurdles. And that's the incentive to drive new innovations in the world of medicine. Now, in the world of digital health, innovations are happening because people are experiencing challenges, but there's no route to market. And so for me, I'm really keen to see a transaction at point of prescription, if you will, to the patient. Now, one of the questions that we've had is around choice. I was just going to bring Henry in, but he's saying that his internet is unstable, so he's dipping out. No problem, Henry. Completely understand. So one of the things that I was just wanting to bring in here is, in the world of medication, we have choice, and as a prescribing doctor or clinician, you are able to find the right drug for your patient. How do we think that we're going to resolve the choice issue or finding the right product for people within this crazy world of digital health, and how do we find the right product? And Chris, I'm going to bring you in again because I know you've done quite a lot of work in patient and healthcare professionals, and what's your take on this?
Yeah, my background was also 10 years in pharmaceuticals, Liz, so I understand a bit about
perfect.
I don't necessarily endorse, by the way, having a similar licensing model for digital tech, because it would slow us down by about a decade and bankrupt just about every SME that I'm aware of. So for me, the the ability for us to try and put a standard in that enables us all to be procured, to make a decision, almost a tariff for digital health tech, would enable a similar type of choice to what you get for pharmaceuticals and for medical devices, for that matter, if they're on prescription. So for me, what would be really useful is that as the health service and the health services around the world go and negotiate a national price within a healthcare system for a drug, if the same type of mechanism was available for digital health technologies, which would require, evidence, require data for that to be negotiated, that would enable clinicians to make a choice. It would enable clinicians, and then potentially, depending on the system you have, patients to also make the choice. And that for me would be a really great step forward. It's worth me adding, there are some frameworks currently being set up in the UK, as well as others internationally, which do enable, to an extent, some of that to happen. Although it's likely that healthcare systems and healthcare regions, so your integrated care systems, etc., across the UK will largely pick one or two of those. But I think a national tariff, a national prescription process for all sorts of digital tech that have that evidence base will, for me, be a really big step forward.
So, I completely agree with that, and that for me is my hope and aspiration is that as a healthcare professional, we start to prescribe digital health alongside or instead of drugs as frequently as drugs and other solutions are prescribed. And there's a couple of questions coming out actually, Chris, from what you've just described, and I wanted to bring Jan in here. Jan, the question is very much around: does the world of entrepreneurs and innovators and companies understand enough about health economics and how you build a return on investment case and how you build clinical evidence to be able to get to the point that Chris has described, and which I completely agree with? So, Jan, really interested in getting your perspective on this.
Yeah, a very good point, and I'm smiling because I don't think so. They understand it properly, and I agree that healthcare is really a different animal to whatever other pieces of startup world. I also do work with 3 startup incubators, so I meet these people very often. Excellent. And and there are different barriers. I mentioned a few of them. One would be the scalability. If I want to, if I build a great solution which is successful in the UK, that doesn't mean it will be successful in Germany, because over there is different healthcare ecosystem. Somebody asked a question about if the startup companies understand or if they maybe underestimate the need for integration. I would say yes. If the data are not integrated with the healthcare providers, then the healthcare providers do not want to use this technology. This is typical thing what I hear from CIOs in hospitals. We do not want yet another 110 solution that we run in our data center. Sorry, no. The physicians don't want to watch 20 dashboards, 20 web applications. No, they just want one. Yeah, so the integration is crucial here. And maybe last point which I add to this is like the financial sustainability of this solution. This is always a big question. Who pays for the solution? Somebody has to pay for that. The software is not cheap. The software is not for free. And very often I hear, okay, it will be the patients. But the patients are expecting it will be my health insurance. And to convince a health insurance company to pay for this third-party app is very difficult. So, to find a sustainable model financially is also extremely difficult.
Yeah, it's interesting, Jan. I think that you shared that you've been working in Germany in the past, and in Germany they've now passed a law from the department, the equivalent of their Department for Health, that said that if a healthcare professional recommends a solution, it will be paid for a national tariff. So we're starting to see some genuine pushes towards this. It's a new law that's been passed. I'm happy to share the details of that afterwards. Mm-hmm. Now, one of the things that is really coming up on a lot of panels and discussions that I'm in at the moment is moving to this world of supporting people and patients through digital. Could we be excluding certain populations? Really interested in people's opinions. There are still people in our communities who don't have access to computers or smartphones, they may not be digitally literate. And this is a topic of conversation that's really come up, particularly since COVID. Chris, really keen to bring you in at this point to get your opinion.
So the answer is, are we at risk of it? Yes, absolutely. I think as far as I'm concerned and we're concerned, unequivocally. That doesn't mean there's not something we can do about it. One of the challenges of that, however, is that during COVID, we've not only become a much bigger software supplier, we've also become a bigger hardware supplier as well, because as we've deployed our solutions, our commitment was that we would not be responsible for digitally excluding people, or indeed excluding anybody from the healthcare improvements we're looking at, which meant that we ended up deploying a significant amount of tablets, phones, as well as testing devices, so what we would call peripherals for people to use at home as well. So I think if it's not considered really carefully, then yes, absolutely, there is a risk of excluding people. But I think there are ways to overcome those challenges. I'm really sad that Henry's not on the call, because I've seen some great solutions using really simple text messaging in Africa. So not what we would call highly sophisticated from a National Health Service perspective, but actually really effective and efficient using the technology that people have in their hands. So I think it's important that every single SME that's working in health considers the equality impact of what they're doing. And certainly when we've been working, we've been doing really close collaboration around the equality impact assessments of anything that we're doing, including digital health deployments. And where we're deploying in GP surgeries, where we've got really challenging socioeconomically deprived areas where we manage the population of those patients, actually that's a really big responsibility.
Absolutely. And I wanted to bring Michael in at this point to get your perspective on this. Have you seen any impact, or do you foresee any impact around this digital excluded communities and what this new world looks like?
I think particularly in the UK and Europe, we've been talking about digital inclusion for quite a while, and we're still not including enough people that could use and benefit the technology. Versus the people that are being excluded for whatever reason. And it's an important point actually to make, because we automatically assume that when we're excluding people, that everybody is included otherwise, and it's not the case. I mean, in rural parts of the United Kingdom, the real challenge is around Wi-Fi connectivity, and access to 4G and 5G, and the operators and the providers aren't delivering those services. So there's no way in the world you could even deliver a service, whether it was to a marginalized population or a non-marginalized population. The challenge is always going to be there with the technology. But I do sometimes think, though, that when we're considering how we will provide technology to people, we're often not giving it to them early enough. So I do see a case where technology is given to people where there's only going to be a marginal improvement as a result of using it. A really good example of that at the moment is in rural Lincolnshire and places like that, where they're providing home care video consultation services with people that can't really use them, and for people that are actually, index-wise, they've got a high risk of mortality or a high risk of developing complications and problems, but really it's that they wouldn't benefit from it in the longer term. Or I've seen examples where people have had sensors fitted into their homes, and they're not really mobile patients anyway. It would have been better if it'd been deployed for people maybe 3 years earlier in the diagnosis. But because of the way our payment systems, our commissioning systems are set up, those people don't really qualify for it. And so we see that as a major issue. But I do think, though, as well as, and going back to the accessibility piece, is that we don't have the right people within in organizations that are actually equipped to make the right kind of decisions about the kind of technology that people should be getting. I think there's a massive educational piece that's missing when it comes to commissioners, providing services to patients, let alone the socially or demographically excluded ones.
Yeah, I think that you've picked up on some brilliant points there, Michael. So I think you know, what we're talking about is we still need to offer choice. We're back to putting the person at the centre and thinking through what their individual needs are and making sure that the services and care that we provide fit those needs. And for me, I think that's a critical point. This is not about giving everybody a digital solution. This is about providing digital where it's fit best. And one of the things that I have loved working in the NHS because they always provide choice, and digital choice is just one of those choices. And for me as a patient, I would welcome that choice more, but for other people in the communities, they would still rather have that face-to-face. And so let's get the right service where it's needed. Now, I am mindful that we are actually running out of some time. This has been a fascinating conversation, but I think one of the things that has really come out for me during today's conversation is, you know, the topic of the conversation was about how do we empower patients or people. And actually where we've gone through in this discussion is we've talked about patients, populations, healthcare professionals and system leaders. And we've also talked about the fact that this is a journey, and COVID has provided us with an acceleration on that journey. And so I just wanted each of the panellists to provide one thing that we need to take from this time to be able to sustain, maintain and grow the use of digital within the world of healthcare. How can we learn from the progress that's been made and grow from it?
Mm-hmm. Yeah, this is a good question. I would have many answers, and I mentioned several times the need for integration of the results and to have integrity in the data and integrity in the, let's say, AI algorithms if it is more advanced. I would like to skip that. I mentioned that several times, but what came to my mind would be maybe to create and publicly support like an, oops, it's dropping. That's Henry, right?
I think so, yes. Technology, hey?
Yes.
Okay.
The joys of technology. Okay, we're okay now. We can hear you, Jan.
Okay. No, I would see as a cool, because there is a lots of small app vendors and small digital health technologies, and it's very difficult to select the right one and educate the physicians and you know, get it to the patients. I would be happy if there was like an incubator or a facility supported by state that would simply create an environment to test those solutions, validate them, approve them that this is a valid solution, and then make them available. I think that would be very helpful.
Thank you, Jan. Very, very quickly, Chris and Michael. Michael, I'll come to you first. What's the one thing that you would suggest as the next thing for us to do?
Well, I'd like to build on the fact that there's been a lot of sort of accelerated, fast collaboration. The speed that people have been making decisions and funding decisions has been quite dramatic. And I would like us to keep that momentum going. You know, I'm not saying invest in any old rubbish. I'm saying invest in stuff that works. But I'm also wanting to see a more consistent, standardized approach around government bodies that want to accelerate, you know, the uptake of tested technology into the healthcare environment. I want to see them do it in a standardized way.
Exactly.
I do have an immense criticism of academic health science networks. I don't think they're all universally great at doing what they're doing. I think government agencies really need to up their game to really make sure that we do fast track these all of our technologies more successfully and integrate them very, very quickly.
Yeah, that's really helpful, Michael. Chris, just very last word, and then I'm going to bring this to a close. Apologies, Michael.
Me, it's about creating the evidence that enables the system to lead on what that looks like from a national perspective. So for me,
thank you, Chris. That's great. I'm mindful of time. People are dropping off and saying thank you very much. So I would like to say thank you to David for organising this opportunity to talk through this exciting. of your day.
Okay, thank you very much to everyone.
Thanks, Liz. Take care.
Thank you very much for everyone for joining this session. Just to finish off with, apart from thanking our panelists for a great discussion and apologising for some of the technical issues we had with Henry's internet connection, I just wanted to say very briefly that our next expert panel discussion will be talking about digital healthcare in Africa. This is going to be on Tuesday, August the 25th, so in other words, a fortnight's time at 2 o'clock in the afternoon.